Hello and welcome to this presentation today entitled Resilience and Respect, Health and Care for Trans People of Color. My name is Olivia Fricke. I'm a certified nurse midwife and currently work as a provider at Family Tree Clinic. My pronouns are they, them, or she, her. For those of you unfamiliar with Family Tree Clinic, we are an independent nonprofit clinic that specializes in reproductive health care and gender-affirming hormone care. I am so sorry that I can't be here in person to present this to you today. I've been looking forward to this for a really long time, but unfortunately myself and my entire household currently have COVID, and so I'm still in quarantine. It wouldn't be safe for me to be there today, but I'm still really excited to share this presentation with you. In terms of this presentation and kind of a roadmap and goals for going forward, I really hope to challenge your understanding of gender and race, get a sense of some of the challenges and barriers to health and receiving care that trans people, particularly trans people of color, face, and then some information about gender-affirming hormone therapy and contextualizing that in the sense of the broader healthcare system, and finally grounding this information in both the concepts of resilience and respect. So let's start this conversation by trying to understand gender. That's a really big ask. And so I have some working definitions for the purpose of this presentation. And so for the purpose of this presentation, defining transgender as someone not identifying with or presenting at gender assigned at birth, defining cisgender as someone identifying as and presenting as their gender assigned at birth. And although these are important definitions in order to be able to have this conversation with like a shared understanding, I also really want to challenge these concepts that this is an easy and clear divide. There is a lot of nuance here that's beyond the scope of this presentation. And I do think that a lot of the news media and a lot of the legislative sessions are trying to really enforce this narrative that it is a clear and easy divide between who is transgender and who is cisgender, when that is in no way true. Some people who identify as cisgender may dress in clothes, have hairstyles, or wear makeup in ways that are traditionally considered not congruent with their gender, and may end up facing similar discrimination and barriers that trans people do, despite not identifying as trans. On the flip side, some trans people may choose not to be out or visibly trans, may never want or need to medically transition, or may have a level of fluidity to their gender that people may not recognize as being trans. And then any other combination that you can think of is going to exist. I really want to challenge you to reframe not thinking of transgender and cisgender as a clear binary, but as a spectrum of identities in which there's going to be a lot of overlap and a lot of gray areas. The amount of variance in gender is impossible to delineate in clear terms, and it doesn't need to be an easy and clear divide. But again, in order to have a shared understanding and be able to go through this presentation today, these are the definitions that we're going to be working with. So now that we have both challenged and defined these terms, let's complicate gender even further by how it intersects with colonialism and race. On this slide is a super brief and nowhere near comprehensive list of cultures that have frameworks and gender categories that are not the binary male-female gender categories. These are gender categories that existed within these cultures prior to colonialization, prior to Western contact. The gender binary became the standard globally as a facet of colonialism and a facet of cultural erasure and dominance. When cultures with different understandings of gender and different gender identities and rules in society were encountered, it was treated as proof of their barbarism or incivility and very intentionally demonized and eradicated as much as possible. Whether it was through forced assimilation, like the boarding schools American Indians were forced to, whether it was through religious dominance, or whether it was through genocide. This has left many of these previously existing understandings of gender inaccessible or with lasting negative connotations, even in the communities they historically existed in. So while some members of these communities in the modern day, while some descendants may be able to reclaim these identities, some may not, or may be actively rejected from their own communities for trying to do so. Also, very importantly, these alternate understandings of gender cannot and should not be interpreted through a modern lens of transness or queerness, and instead are important context to really push back against the narrative that the binary gender system of male and female is the only or the inevitable or the logical way to define gender. It very much is not, and its cultural and global dominance is a direct product of colonization. So, to further this conversation, the ways in which gender and race are tied. The gender binary, as we are taught to understand it and as it is upheld by the dominant societal structures, is inherently racialized and defined specifically in opposition to people of color. In the colonial era, as white Europeans sought to legitimize their inherent superiority over non-white people, gender was one of the ways in which they did so. This was during the era of phrenology, a discipline of pseudoscience in which measuring people's bodies and facial features were supposedly able to discern their character, their worthiness, whether or not they had criminal tendencies, etc. And it was also used as a way to prove that BIPOC individuals were somehow inferior and that they were not evolved enough to differentiate between male and female. Although not as explicit now, these same concepts that hold BIPOC people as not correctly performing gender still exist within the public consciousness. Black people are treated as hypermasculine and hypersexual, both men and women, and prominent black women like Michelle Obama are accused of being not feminine enough or secretly having male genitals. East Asian men are considered less masculine, are mocked and cast as comic relief instead of as leading men or love interests, and those are just some relatively common stereotypes that exist in the media and in conversation. And there's so much more, and it is ugly and unpleasant to really look at, but they really are important to bring to the conversation. They create stereotypes that people are receiving, and they feel that they either have to somehow disprove or play into. They're receiving this every day through media, through microaggressions, etc. And fundamentally, what it is doing is it is increasing the level of scrutiny of the gender of people of color from both extrinsic and intrinsic sources. So returning to the modern day, and specifically transgender people of color, what does this higher level of scrutiny of their gender mean for them functionally? Again, to answer that question fully goes far beyond the scope of what I can do today. But I really want to zero in on some of the key ways it impacts people's lives. One of the big facets of life that it visibly impacts is employment. So this is data here from the United States National Transgender Discrimination Survey, and it was conducted in 2008 and 2009. And so with the current state of negative attention on transgender people nationally, with all of the things that are currently going through various local and state level legislative sessions, I would really be unsurprised if these numbers are actually worse currently than they were a little over a decade ago. So I'm choosing to start here with employment because functionally it's how people are able to function in society and being able to meet their basic needs is through having a steady income. A lack of income leads to food and housing insecurity, and it can keep people in dangerous places or relationships. And at the very least, it's going to add a significant amount of stress to someone's life. All of these are going to be detrimental to someone's overall health. Also, inescapably in the United States, healthcare is explicitly tied to employment through health insurance. And in case anyone hasn't noticed, healthcare is really expensive, even if you do end up having health insurance. And so if people are being denied opportunities or not being employed, that's creating pretty massive barriers to their ability to receive care for anything. So I have statistics here about unemployment rates, which, as you can see, about double for all transgender people, about 4 times as high for Black transgender people, and again, continuing across all of the categories that were polled in this study. And then similarly for employment discrimination, already high for transgender people, and then significantly higher as we go into each of the various identity groups. And same for losing a job due to being trans. This data goes on with a similar trend for things like being denied promotions, being underemployed in one's field. Despite having actually an inverse relationship, transgender people as a whole are actually higher educated than cisgender people in this particular study, but that does not reflect in their earnings or in their employment, unfortunately. So I have a de-identified quote here from that same study that really speaks to this. This quote really exemplifies how denying people a steady income and denying people health insurance functionally denies them health care, and functionally really denies them the access to being healthy overall. So now let's move on to talking about healthcare systems and some of the barriers here. So in terms of transgender people trying to interact with the healthcare system in general, trans people, like everyone else, will need routine checkups, will have health concerns completely unrelated to being trans. They'll need to see a dentist or a primary care provider or go to an emergency room. And this is the conversation that we're having in this slide. So, unrelated to necessarily transgender-related care, 19% of all trans people were just refused medical care, and it was higher for people of color, highest in particular for American Indians, at like over a third. And then again, when trans people chose to disclose to their providers that they were trans, they all faced a significantly higher rate of discrimination, highest within the Latino community, which had about 32% by doctors and hospitals and up 19% in emergency rooms and mental health clinics. Before we go further into discussing healthcare, I want to really touch on the fact that there are some important health disparities that I'm not going to go deeply into in this presentation. So transgender people and transgender people of color are going to have significantly higher rates of some triggering things like suicide, interpersonal violence, and rates of HIV. And there are some people and communities and advocates that are really entrenched in doing this work. And in order to really contextualize and dive into all of those disparities, the work that's going around them, etc., that would really require a whole presentation into itself. And I really want to stay focused on the high-level healthcare barriers, about just how interacting with the healthcare system as a whole is so fraught with barriers and discrimination. So here we have another de-identified quote from the National Transgender Discrimination Survey, which really illuminates the very thinly veiled transphobia that people are facing when they're trying to receive healthcare. And then to really further this, about 50% of all the trans people polled reported that they had to teach their provider about their medical care. So let's continue this conversation about healthcare by just taking these providers at face value and say that they really may not know what they're talking about and may feel uncomfortable providing healthcare to trans people. There is some truth to the sense that most medical programs and advanced practice nursing programs do not have any curriculum related to caring for transgender people. This is an added competency that clinicians have to seek out for themselves. That being said, looking up evidence when someone is unsure of how to care for someone is fundamental to good clinical practice and should not create a massive barrier for caring for trans people. So there are currently 3 main bodies that have released detailed information about how to safely and thoroughly care for trans people's health. So the WPATH, or the World Professional Association for Transgender Health Standards of Care, releases standards of care that is incredibly in-depth and is informs how to safely practice gender-affirming hormone therapy. The University of California, San Francisco releases the guidelines for primary and gender-affirming care of transgender and gender non-binary people, as well as the Endocrine Society has the endocrine treatment of gender dysphoric, gender incongruent persons, and Endocrine Society clinical practice guidelines. These are massive documents that go into both high-level and pretty nuanced detail work about transgender healthcare. And all of these resources are available for free online without any institutional access, without having to pay for anything. And so any clinician would be able to access all of this information. And again, kind of delegitimizes any claim that they're making that they aren't knowledgeable enough, don't have the resources to be able to provide this care, and really emphasizes that it's a choice and it's a way to deny people care for being trans. And then, also importantly, from the WPATH most recent standards of care document, for the most part, the general health and well-being of transgender people should be attended to within the primary care setting without differentiation from services offered to cisgender people for physical, psychological, and sexual health issues. So when transgender people are seeking care for general things, whether it's an emergency room visit, whether it's care for chronic illnesses, or whether it's mental health concerns, there really isn't an appropriate reason to feel that they are somehow more medically complex simply because they are trans. So now let's do a really brief discussion of gender-affirming hormone therapy. We've already kind of discussed on the fact that the average practitioner should be able to see transgender patients and have resources to do so, etc. But there is this kind of like mystifying conversations around gender-affirming hormone therapy that makes it seem a little bit inapproachable. So let's talk a bit about it. The nuance and monitoring, etc., is not really our goal here, but just a sketch of kind of what's important for clinicians who are seeing patients who are on gender-affirming hormone therapy being managed by someone else should know. So in terms of gender-affirming hormone therapy, everyone in their bodies has estrogen and testosterone in an inverse relationship, where one is high and one is low. The goal of gender-affirming hormone therapy is switching which hormone is higher, which hormone is lower. This will result in some physical changes that are kind of like the desired purpose. And so when estrogen is more dominant, people will notice things like breast development, fat redistribution more into like the hips and thighs and buttocks, kind of a reduction in muscle mass, softer, smoother skin, reduction in facial and body hair. When testosterone is more dominant, we're going to notice things like a deeper voice, more facial and body hair, bottom growth, and other things. So that's kind of the very basics of gender-affirming hormone therapy. But let's talk about the risks. Any medication is going to have some sort of risk profile associated with it. And so let's talk about the risks specific to this. So here I have broken down the list of risks that we're going to be counseled on by gender-affirming hormone providers, and that patients and clinicians should be aware of. And these are some pretty serious things that we have on this list, and I really don't want to minimize them in any way. And perhaps could contribute to the sense of a clinician feeling that a patient is more medically complex and don't know how to take care of their primary care or other health needs. But again, I really want to challenge that, because although many of the things that we're seeing here are relatively serious, they're also not particularly uncommon. Also, in the risk of breast cancer under estrogen, that's an increased risk compared to assigned male at birth counterparts, but it's like a similar risk to cis women. So risk of the general population of some of the same things that we just saw on the other slide. So as you can see, relatively common for people to have type 2 diabetes. On the previous slide, we mentioned decreased bone mineral density, so that seems like osteoporosis. Again, quite common in people past middle-aged. More than half of Americans have lipid abnormalities. Heart attacks, incredibly common. And then the risk of blood clots is going to be higher on estrogen therapy. It's about 2% for all users. The risk for general population is about 1%, but the risk for cis women that are on estrogen-containing forms of birth control, that's about 3 to 5 times higher than the baseline risk, so it's going to be higher than that 2% we just discussed there. And so the reason I bring all this data into here is not to minimize the risks, but to really contextualize the fact that clinicians, whether they're in an urgent care setting, whether they're in an emergency room setting, or whether they're in a primary care setting, are already dealing with these potential health complications. So even if a person on gender-affirming hormone therapy is facing active adverse effects related to their gender-affirming hormone therapy, these are still really common things that should be able to be identified and managed and treated. And again, not of legitimate or like acceptable reason why someone would think that someone is too medically complex to be able to care for them. And then this table here is just about risk of blood clots. And so this is data about cisgender women. And so you can see that the kind of average risk is that highest, smallest bar, non-pregnant, non-COC user. And then this is the bar for people using birth control, and then pregnancy, and then after birth. And as you can see, this is like much, much higher as we go in. And then the risk of transgender women on estrogen would be between the first and second bars. So finally, let's wrap up our discussion with talking about respect and resilience. What so much of the statistics and information we have reviewed really demands is respect. Respect for people's identities and lived experiences, respect for the historical and like ongoing cultural context in which people's identities are going to be framed in, respect for people's right to be in society, to be gainfully employed in their chosen field at the appropriate level, and to self-determine who and when to disclose their identity to, and respect within the healthcare system for all parts of their physical and mental health without discrimination and without this like thinly veiled or even openly hostile transphobia. And so there are some really simple action steps on this slide. And it's also important that people who have the opportunity to be allies and cause changes in their institutions or workforces do so. So, always respecting someone's names, pronouns, and lived experiences. Really important to not assume poor health, not assume someone is a sex worker, not assume that they are health illiterate, or even to assume that they are suffering. I do think that sometimes people think they're being an ally and end up overstepping boundaries and really being patronizing or pitying in a really inappropriate way. And so, just respecting someone as a whole and capable person, and not bringing up triggering or traumatizing things that are not relevant or being brought up in the visit at the time. That includes things like not using a gender dysphoria code for someone if you're not treating them or discussing gender dysphoria with them, or if you really feel that it's important that you add that diagnosis code to your charting system, making sure that they're okay with it. Because that is something that communicates with other electronic health records, and if they are not out to all of their providers, or if that's something they're not comfortable with, that could put them in genuine danger. And then also, obviously, advocating for patients and community members whenever possible. I think a really good example of the ways that systems can be less transphobic and create less barriers for people is at Family Tree Clinic, we actually have a prior authorization specialist. Shout out to Ernie, who's amazing. And the role of the prior authorization specialist is to help navigate insurance coverage. Oftentimes, health insurance, although they say that they cover or are meant to cover transgender hormone care, will require something called a prior authorization, which is basically an extra step of complicated paperwork that says, is this medically necessary? And you have to resubmit it back to the insurance with the correct forms and say, yes, it is. And then if you do that, then they usually end up approving it. A lot of the time, that burden of doing that work and communicating all of these really specific things and documents to the health insurance system is expected to be put on the patient. And by having this full-time dedicated staff member at Family Tree Clinic, that is a massive burden that we are able to take away from our patients, and one of the ways that we're able to reduce the healthcare barriers that trans people are facing. So let's end with the concept of resilience. There are a lot of various definitions floating around in the realm of psychiatry and psychology, but that's where the term is kind of grounded for this discussion today. And what it really boils down to is the ability to move on from difficult or traumatic situations. There are handfuls of studies in this field that particularly look at resilience in transgender people of color. So this is from Maureen G. White's PhD dissertation entitled Resiliency Factors Among Transgender People of Color. And these were specific factors that were named of resiliency when interviewing the study participants. And so, as you can see, one of the most important areas of support that contributed to resiliency was just community. And that's one of the most important things that you can take away from this, is that someone having to face all of these barriers alone, without social support, without emotional support, without structural support, is one of the hardest parts, and one of the ways in which resiliency can be supported for peers and for loved ones and for community members. Also, the majority of participants were future-oriented with personal goals, which is another factor that contributed to their resiliency. From that same study, some of the shared personality characteristics of these people in interviews that they felt contributed to their resiliency was being outspoken and strong, independent, friendly and outgoing, being private, which also speaks to what we talked about earlier about having higher rates of discrimination when they disclose their identities, being leaders and role models, and having determination, which are all just remarkable characteristics in anyone. And so another study from 2011 by Singh and McCleroy found these specific dimensions as important to resilience for transgender people of color. So pride in one's gender and ethnic or racial identity, recognizing and negotiating gender and racial and ethnic oppression, which is why I kind of started our presentation right there, because you cannot unlink, you cannot separate gender and race and transness, and you cannot separate that from its colonial and racist history. And then navigating relationships with family of origin, accessing healthcare and financial resources, again, why we talked about employment so extensively, and then connecting with an activist transgender community of color, amazing, and cultivating spirituality and hope for the future. This is a wonderful quote from that same study that I actually will read for you verbatim. Society put me in a place where I am a minority and doesn't think I have the talent or potential because of who I am racially or ethnically. When I was a child, didn't think my ethnicity was anything to be proud of. I was looked down on because I was black, and then being transgender made it even worse. Now that I'm older, I'm proud of everything I am. I am an African American transsexual woman. No one can tell me I'm less than anyone else. That helps me no matter what bad things happen to me. Some days, just getting out of bed is a revolutionary act to deal with the world, and I make sure I get out of bed. And this was a study quote from Marla, a 45-year-old woman who identified as African American and reported her gender as MTF. This quote is amazing and really summarizes kind of what we're talking about, that despite all of these persistent societal barriers and acts of discrimination, transgender people of color are showing so much resilience by just being themselves, by finding their health, by finding their joy, by participating in their communities. And it's just something that we really need to focus on, support, and uplift. And this study, this study is actually named after this quote. The title of the study is "Some Days Just Getting Out of Bed is a Revolutionary Act." That's how powerful this quote is. So I want to end this presentation with a reflection question. Ask yourself, do I believe trans people of color can have long, healthy, fulfilling lives? And with all of the data, with all of the rampant transphobia, with all of these disparities and health barriers, I think it's really easy to fall into the trap of being concerned, of being worried, of not believing in someone's ability to thrive. And I really want to take this moment to ground in a resounding yes, trans people of color can, will, and should have long, healthy, and fulfilling lives. And they are working every day to make sure that they are doing so. And it is our job to make the work of that easier for them. Whether that is making changes in our workforce, whether it is making intentional moves to try to hire people, whether that is putting money into organizations that are creating community, whether that is voting for candidates that are going to pass helpful legislation, or whether that is just being a good friend, a good partner, a community ally. However you can think about it, it's important that you do the work. It's important that you think about it. And it's important that you believe wholeheartedly that it is a remarkable thing for trans people of color to simply be themselves, and it is something that we can absolutely support and celebrate every single day in any way that you can think of. Thank you so much for going through all this information with me. Now I have a whole bunch of slides with references that I'm not going to hang out on. But here's my contact information. Again, I'm really sorry I can't be here today to answer questions. But this is my email, ofricke@familytreeclinic.org. Feel free to send me an email. And if you are in the market for any sort of gender-affirming hormone therapy or reproductive health care, we would love to see you at Family Tree Clinic. This is our clinic phone number. And everyone is welcome there, and we hope to be able to help you meet your healthcare needs. So thank you so much for paying attention. I hope that this gave you some interesting frameworks to kind of think about and mull over, and I hope you have a wonderful weekend.